Now I'm going to invite Professor Mansoor Khan. Professor Mansoor Khan graduated from the King's College London in 2000 and he obtained his FRCS in 2010. During his service at Royal Navy, he has deployed extensively in multiple places around the globe, including Arabian Gulf and Gulf War in 2003, and counter-narcotic operations in the Caribbean. And also he has deployed to Camp Bastion, Afghanistan, and also South Sudan during the UN missions. Recently, he retired from the Royal Navy as Surgeon Commander and currently serving as an esophagogastric trauma surgeon and honorary clinical professor at Brighton and Sussex University Hospital. Over to you, sir.
Many thanks for the opportunity to present at this very important meeting, the first joint collaboration between the Ambrose Paré International Military Surgical Forum, as well as the Asian Collaboration for Trauma. So my talk today is going to be on a very, very interesting topic, I would say that because I'm given it, which is the advances in trauma care due to conflict. Now, as with any of my talks or any talks that anybody gives, this is my disclaimer. The views of this talk, or the views in this talk, represent my views and are mine alone. So what do we think about when we think about military medicine? Okay, we're talking about forward combat hospitals, and especially in the evolution, we're talking about individuals dressed in white clothes, white scrubs, white gowns, operating in trenches. But I'll tell you, it probably goes a bit further than that. And you're all fed up probably of this quote, which is a adapted form from Hippocrates saying, an individual who wants to learn surgery must first go to war. In fact, he didn't say individual. He was rather dogmatic in the gender stereotyping he had. So what I've done is paraphrased it. And please spread this around. It will gain me infamy. An individual or a system that wants to learn surgery must first go to war. Why do we have to go to war? What happens at times of war which advances medicine? And why does medicine advance? Well, the reason why it advances in times of war is because we become more and more developed in the weaponry we use, in how we maim individuals, in how we cause devastation to individuals, both on an individual sense and also in a wider group. And if you look in the top left, you've got fists. Okay, the original weapon was your hands. And the further right you go, the more you develop kinetic energy weapons, such as the mortars, the field guns and the cannons. And the further down you go, the more you develop, first of all, the penetrating weaponry. And then finally, you get to the guns, okay? All related to penetrating trauma and kinetic energy. But that's a totally different talk. Over the last 200 years, technological advances have occurred and medical advances have endeavored to keep up. But unfortunately, due to the funding streams, weapons will always be slightly ahead of the medical care. Now, I'm not saying something controversial, but if you think about how much money is invested into developing weaponry and how much money is put into actually providing healthcare, you will see the imbalance, the joys of being retired. Advances have come due to profound needs. So at times of conflict, you do need certain aspects of medical care, whether it be surgical, trauma, medicine, disease prevention, all of that lot. But the key thing here is these advances would have occurred by themselves, but have been accelerated in times of conflict and in war. Now, for the youngsters amongst us, I'm going to break this down into the olden days, i.e. the era where I trained, which was prior to the year 2000, and modern day, which is after the year 2000. And there will probably be quite a number of members of the audience who were born after the year 2000. So come back with me through a journey in time. So the olden days, 500 years ago, okay? Talking 1600s, the best a casualty could probably expect was to be dragged off the battlefield. If they were bleeding, if they'd lost a limb, if they were massively injured, they'd be grabbed and dragged off the battlefield through the mud in a hope to get them to some form of care which would lead them to survive. And this some form of care was very rudimentary. It was the bleeding leg would have a hot iron put on it to try and cauterize it, or sealed with boiling oil. Nice thoughts, huh? So our journey through history continues. If we go to the siege of Turin in 1537, a French barber by the name of Ambroise Paré, you notice the reason I've chosen this, was deployed to Turin, and he noticed the horrific medical care that was, people were dying from hemorrhage, and he was like, why is this occurring? So what he did was relearn anatomy, relearn basic surgical techniques, identify arteries and time them off, the so-called ligature. What's really, really depressing about this was these skills were known to the Arabs and to the Romans. So thousands of years beforehand, they were just forgotten. And now they were being relearnt, not reinvented. A lot of modern medical literature tells you inventions have occurred where all they're doing is putting their name and a name of a technique to something that has already been practiced. More controversy. The Napoleonic Wars then came along with the surgeon-in-chief to Napoleon by the name of Dominique Jean Larrey. Now, I apologize if I've totally massacred that last name, but my French was done for the first 2 years of my GCSE, and since then has become rather rusty. But what he noticed was artillery was able to move around the battlefield quite quickly because it was in horse-drawn carriages, horse-drawn apparatus. And he went, hang on, if we can do that for our artillery, why can't we do that with our injured personnel? And the first so-called flying ambulances were invented. The American Civil War looked at a slightly different aspect. What we've looked at currently is hemostasis and the evacuation of casualties. What the Civil War brought to us was significant usage of general anesthesia. And yes, for my American colleagues, that is how you spell anesthesia. And it was discovered in 1846, apparently. And prior to this, the gold standard for operative care was the speed of surgery. How quickly you can do the amputation, how quickly can you get hemorrhage control, how quickly can you debride tissue. It was the speed that mattered. However, as we all know, when you're doing stuff at speed, you cannot develop technique. And what general anesthesia allowed was for advances in surgical technique to be developed. World War I came along, where yet again, what we've now got is surgical technique, anesthesia, hemostasis, and evacuation. But how are we going to fill up what was lost? World War I brought about blood transfusions. Prior to this, they were really extremely rare. And what happened was, right at the front line, aid stations located close to the battle areas, you could actually go and donate blood and store it, and this was whole blood being transfused. Notice, whole blood at the point of injury. It's almost like we are reinventing the wheel. Also, World War I even, led to the development of chemotherapy. Chemicals and poison gases were found to be killing normal cells. And someone came up with the idea, hang on, if it can kill normal cells, why can't we adapt them to kill cancer cells? And therefore, molecules were developed to specifically target cancer cells. Now, if we go back to our evacuation of casualties, where 500 years ago, we're dragging them, then we're loading them onto horse-drawn carriages. And what do we do here? We start to retrieve casualties under fire. We're using vehicles powered by gasoline to retrieve these casualties. So gasoline became the world's first pre-hospital fluid. How apt that we still think this is probably the most important thing. And there is a movie out there which you've all seen, probably one of my favorite movies in recent years, which shows how American Quakers, conscientious objectors, were at the front line of evacuating these casualties. And altogether, this intervention led to an increased survival of casualties. World War II, you know what? Led to advances in antibiotics and usage. Sulfur drugs were discovered in 1935. Penicillins were used in 1939. And prior to this discovery, infections were the leading cause of death. You may think, oh, hemorrhage was, but people who were injured, who survived the hemorrhage aspects, died of infections, okay? And without probably the Second World War, it would have taken longer for this to be adopted. Also in World War II, metal plates were first used to treat fractures. This was developed by the German military medical services and were only discovered by accident when German prisoners of war were medically examined and found to have cuts on their limbs, and when x-rayed were found to have metal plates. These doubled the recovery time. So basically, not double the recovery time, half the recovery time, if you know what I mean. So if somebody was healing at, say, 2 months, they would heal in 1 month. At 3 months, they would heal in 6 weeks, and increase the speed of recovery and allowed patients to return to their active role quicker. Now, without the advent of antibiotics, this would not have occurred because, as you can imagine, probably contaminated wounds, debridements happening, but you need that antibiotic coverage. So sometimes conflict developments work in synergy. Then we get to the Korean War. You know how we talked about dragging, horses, vehicles. Now we have airborne vehicles, helicopters used for evacuation, decreasing the time to definitive care. Also, the hospitals were brought more forward. You're bringing them close to the casualty. So so-called forward surgical teams were already being developed. So not only do you have quicker evacuation, shorter recovery times, but you're also bringing the medical care forward, okay? And one of the other things, this goes on from the literature. If you remember, Ambrose Paré was tying off vessels during the Korean War. They found out that revascularization of these vessels, even with temporizing shunts, was of great benefit. Now, Vietnam War came along, and this brought along a lot of developments, but some of those were due to the weaponry used, okay? So what we could do here is, in World War I, we were using fresh blood right there, which had a sell-by date, but with the Vietnam War, fresh frozen blood products, which could be stored from anywhere between 9 to 30 days, okay? They could be obtained and stored in large quantities, dependent on the freezing apparatus. Also, due to the weapons used in Vietnam, there were significant advances in burn care, okay? Antibiotic and antiseptic dressings were used. There was also a greater understanding of fluid management, especially from these burns patients. Given the climate as well of the area of conflict, this is where acclimatization was also brought in. So during the transport of the soldiers to their destination in ships, they could acclimatize in the humid environment. So when they arrived, they could be so-called fighting fit. And also the first recognition of PTSD, which historically used to be malbranded as shell shock, as cowardice. We actually found that there was a medical reason why this occurred, allowed for greater recognition and intervention, and unfortunately still to this day not managed with the appropriate resources, and still one of the leading causes of mortality in veterans. So the modern era we're getting to now, okay? And this is where I'm just going to lump it in. I'm just going to throw in Afghanistan, Iraq all together, because that is the bulk of what we have known for the first 2 decades of this millennia. What brought about? As I told you beforehand, Ambrose Paré came out with, how can I tie off these vessels? But at the point of injury, if you can get a tourniquet on within a matter of seconds, you can stop the person hemorrhaging to death. All soldiers, all emergency medical personnel are taught how to put these on, and they do save lives. I always state, if you look at the Afghanistan data, if you got on to the Mert helicopter, which we'll come on to next, your chance of survival was 98%, irrespective of injuries, if you had a pulse when you got on there. Now, what we also did during the Afghanistan war, remember what I said during the previous wars, we brought the hospital closer to the casualty. But what we're doing here is we're decreasing the timeline, but we're sending medical care, because these will always have physician providers on board to provide the medical care. The speed of evacuation, the average time from point of injury to reaching definitive care in Helmand province in Afghanistan was circa 35 minutes, okay? Also did targeted balanced transfusion, whether this be TEG or ROTEM directed, or we aspired to the 1-to-1-to-1 transfusion. My personal preference was to give the plasma first And I do believe that some of my colleagues around the world do use freeze-dried plasma as their resuscitation fluid instead of anything else out in the front line, because it can be carried and in any temperature environment. For those of you who are savvy on Twitter, especially on the recent Lancet article, which I read this morning, TXA, you know what? Saves lives. It just does. People try and dissect it and say, oh no, in this caveat, it doesn't. Well, you know what? If applied properly, it saves lives. Also, expertise. The more you do something, the better at it you get. So expertise is of paramount importance. That is why during the Afghanistan conflict, a lot of casualties survived and did better. I'll come on to that point in a second. And then finally, let's not forget rehabilitation. It's no point doing massive interventions if an individual is left with massive disabilities and unable to function. So conflict has also led to developments in prosthesis, post-trauma care. We've still got a hell of a long way to go, but we have made a start, and this requires massive investment from governments to further develop. This is what I'll tell you about the survival you get. If you look in 2003 from the Iraq and Afghanistan conflicts, you can see an NISS of 75, virtually 100% mortality rate. You still have a few individuals who may survive, but by the height and towards the end of conflict, you can see nearly 15% increased survival there. Probability of survival had almost, I would say, gone up fourfold. And this was done due to institutional memory and training. So the last century, i.e. the olden days, the drive was to get the casualties off the battlefield. In this century, the emphasis is to take the trauma care to the battlefield. Does this work? Well, I'll show you. Afghanistan, in the early years, 20% fatality rate. Afghanistan, at the end of conflict, 8.6% fatality rate. Now, the question we ask is, do we need to wait for the next war to develop or accelerate medical care, or what can we do to accelerate it now before a conflict starts? And it's great to have Colonel Avi Benov on, because we have discussed this, and hopefully you will see something coming from a joint venture in the not too distant future. Thank you very much for your attention, and I believe it is time to start with some questions.